Thank you, Professor Mueller. Ladies and gentlemen, it gives me real pleasure to be here in Florence today, the heart of Europe, on the day that Boris Johnson got fired. And as you've heard, I'm Andrew Chapman. I'm a clinical lecturer in cardiology from the University of Edinburgh. And I have a lovely topic to discuss in just 10 minutes. What are the challenges in type 2 myocardial infarction? So it's difficult to know where to start, but I'll try and give you an overview. We all are familiar with type 1 myocardial infarction, an event which occurs due to an atherosclerotic plaque rupture, intraluminal thrombosis, distal ischemia, and infarction. But the universal definition has introduced a concept of type 2 myocardial infarction, which we can think of as an umbrella term which encompasses coronary mechanisms of MI, which can include spontaneous coronary dissection, embolism, vasospasm, and it also includes patients with fixed obstructive coronary disease and patients who may have no coronary disease at all. So it really is an umbrella term. And we know that the prevalence of type 2 myocardial infarction varies depending on whether we check troponin levels in all patients who come into hospital, or if we only check troponin levels in patients who are very unwell with another problem. And as illustrated on the right-hand plot here, there are a number of different mechanisms of type 2 myocardial infarction. And the systemic mechanisms may include hypotension, prolonged tachycardia, or tachyarrhythmia, or indeed hypoxia. Outcomes for patients with this condition are very poor. We've previously demonstrated that patients in blue with type 2 myocardial infarction, as few as 1 in 3 are actually still alive at 5 years after diagnosis. And when we look at the specific cause of death, we can see that the future event rates of type 1 myocardial infarction, or death from a cardiovascular cause, are still quite high. So that's shown in gold here on this panel, with patients in red having a previous type 1 myocardial infarction. And that is despite this significant excess risk of non-cardiovascular death, similar to the response Dr. Lowry gave you regarding frailty. When we look at the event rates of future type 2 myocardial infarction in patients who have already had a type 2, they are at 6-fold increased risk of having a recurrent event within 1 year. So these are patients with real cardiovascular risk. And what is the challenge? Well, let me illustrate that for you with a diagnostic case. So this is a middle-aged male patient who presents to hospital with fever, breathlessness, and cough, having been breathless for a couple of days. And he describes an ischemic sounding chest pain. This is his ECG, which demonstrates, I hope you'll agree, a left axis deviation, a left bundle branch block, and a tachycardia in sinus rhythm. He's febrile at 38.9, he's got an oxygen requirement, he has a CRP of 160, he's got a troponin of almost 6,500, and he has evidence of consolidation on a chest x-ray. So if I can just ask you for a show of hands, do you think this patient has a type 1 myocardial infarction? A type 2 myocardial infarction? Anyone? Acute myocardial injury? Okay. So he had chest pain. So he's had ischemic sounding chest pain. He's got a troponin rise of 6,500. And he's got an ECG that demonstrates a left bundle branch block. So yes, he does have evidence of ischemia and a troponin rise. Okay, so there's some voting for type 1, most voting for type 2. So this patient was enrolled in a study called DEMAND-MI, which was the first prospective observational cohort study in type 2 MI, and he had an invasive coronary angiogram. The left panel demonstrates his right coronary artery, which is subtotally occluded. The central panel demonstrates that he's got a severe lesion in the proximal left anterior descending, and the right panel demonstrates the LAD in a vertical plane, and again he's got this very tight lesion at the top, just coming in here. And this lesion was interrogated using a technique called optical coherence tomography. This gives you a bird's eye view down the coronary artery, and it allows you to look at plaque morphology and evidence of clot. And it should keep playing, and hopefully what you'll appreciate just towards the bottom is that there's a plaque rupture and there's some clot and thrombosis here. And on the right-hand panel, he's had a cardiac MRI, and he's got late gadolinium enhancement in an area consistent with the LAD territory. So this is a patient that we now know has had a type 1 myocardial infarction, and it's important to remember that you have a pneumonia, you have a pro-inflammatory condition, and your risk of a plaque rupture MI is actually 3-fold higher within the first 90 days. And this is one of the challenges of type 2 myocardial infarction. So in DEMAND-MI, we took 100 patients with a clinical diagnosis of type 2 MI, and we really carefully selected these patients. And we got it wrong. We got it wrong 7 times. So 5 patients had plaque rupture or thrombosis, 1 patient had myocarditis, and 1 patient had a stress cardiomyopathy. So these are very difficult distinctions to make in clinical practice. And the guidelines talk about these conditions as 2 separate entities, but in actual fact there is undoubtedly a grey zone. And the use of different imaging modalities can certainly help us to try and integrate and differentiate between these conditions. But at present we don't really have an optimal approach as to how to do this best. So which patient should have a coronary angiogram? So the guidelines say that if there's diagnostic uncertainty and ambiguity about whether someone might have had a plaque rupture or thrombosis, then they should have an invasive coronary angiogram. We know in studies of consecutive patients that this very rarely happens in practice in type 2 MI. Less than 10% of patients will come forward for angiography. So patients who have a higher peak troponin, patients with limited supplier-demand imbalance, patients with persistent symptoms or very clear regional ECG changes might be more likely to have an acute coronary lesion, and perhaps they're the patients you should be considering taking forward or having a lower threshold. Those who are older or more frail or who have more generalized patterns of ischemia, or if it's short-lived in the context of a very significant stressor, you might be less inclined to take them forward. But that's a non-evidence-based recommendation. Can novel imaging techniques help? Well, this is two different techniques which are in development at the moment. On the left side, there is an 18F GP1 thrombus tracer, which is essentially looking for evidence of clot. And the lower panels demonstrate here clot in the circumflex artery and also clot in the left atrial appendage in a patient that presented with rapid atrial fibrillation. So he's had a presumed embolic event. So this is a research technique which may well be interesting in the future. And we also can use CT imaging to look for markers of plaque characteristics. So we know low attenuation plaque is highly prevalent in patients with type 1 myocardial infarction and less prevalent in patients with type 2 myocardial infarction. And that might also be a helpful non-invasive adjunct that we can use. Can biomarkers help? This is predominantly a biomarker meeting. Well, researchers from the APACE group have previously shown us that some of these biomarkers can discriminate between type 1 and type 2 events. These are predominantly markers of vascular stress or atrial stretch, rather than any specific marker related to the pathology of type 2 myocardial infarction. And it's also been shown by other groups that these biomarkers can help with discrimination, predominantly in the research area at the moment, though. And thinking about susceptibility to myocardial infarction, well, there are patient factors related to the illness. There are undoubtedly coronary factors related to whether someone has undiagnosed coronary artery disease. And there may be structural factors if patients have got undiagnosed hypertrophic cardiomyopathy or valvular heart disease. And I like to think of coronary disease as a bit of a spectrum. So hopefully myself, I don't have any obstructive coronary artery disease. So if you give me SVT and my heart rate goes 190, I hope I could tolerate it for a reasonable length of time. If you turn that on its head and you take someone who's in their 70s who may have undiagnosed obstructive coronary disease, if they have atrial fibrillation for a shorter period of time, they might develop ischemia. So it's thinking about the underlying ischemic substrate and how we might modify that in future risk, I think, is quite important. And in DEMAND-MI, again, we looked for the prevalence of underlying cardiac disease. So 1 in 3 patients with type 2 myocardial infarction in our study had obstructive coronary disease. And 1 in 3 patients had evidence of LV systolic dysfunction. And these were previously unrecognized in over half of participants. So a very high burden of undiagnosed cardiac disease. And we want to try and understand if we can deliver a randomized trial in this population. So I've been funded in Scotland, and I'm very pleased to say that we will be able to recruit 60 patients with type 2 MI, and we're going to randomize them one-to-one standard care or intervention, which will be a consideration of cardiologist assessment, determination of likelihood of LV impairment or coronary disease, and appropriate investigation and secondary prevention. And I really hope that this will be a step towards a large international multi-center trial that we can power for clinical outcomes. So in the last 20 seconds or so, just to conclude, type 2 MI is highly prevalent in clinical practice, but we know this is a real problem. We don't have sufficient prospective evidence in order to tell us what to do with these patients, but we're trying. We think imaging with CT coronary angiography, invasive angiography where required, and plaque imaging can be crucial in clarifying the diagnosis. There's undoubtedly a large burden of unrecognized coronary and cardiac disease, and randomized controlled trials are the way forward that will allow us to demonstrate benefit, hopefully, and direct our future efforts. Thank you very much for your attention. And if I could just put that last slide up, just as a first time in the senior investigator session, I really do have to acknowledge the hard work of the fellows that were on my slide, particularly Dr. Bilarga, who can't be here today, Dr. John Hung, and many others you'll see. Thanks again.
Fantastic, thank you. Questions on type 2 myocardial infarction? Until the first one from the floor, I may start. The universal definition of MI would argue that the first patient that you have presented because he had fever and systemic infection might not be considered type 2 myocardial infarction because this might be septic or whatever. So how strict are you with your definition? Would a patient with fever, if he's tachycardic, still qualify for type 2, or should he be called kind of cardiac other injury? How do you use the term in clinical practice?
Excellent question. So I think it comes back to where is the evidence for supplier-demand imbalance. So that's a patient who's got clear evidence of hypoxia and tachycardia and a febrile illness. So you could potentially argue it in either way. I think at the moment there's no consensus as to the use of fixed criteria. Professor Tegeson and Dr. Sabi, that he used to work with, did previously propose very strict criteria for supplier-demand imbalance, but we don't use them in practice for the reasons I illustrated around the case with SVT and atrial fibrillation. So I think, having met that patient in practice, he clearly described ischemic chest pain radiating to his left arm, his neck, his jaw, in the context of supplier-demand imbalance. So I was quite comfortable that the clinical diagnosis was type 2 MI, and his imaging evidence supported that rather than myocarditis.
Payment, please.
Thank you for this presentation. My question is related with the emergency department always. In patient with acute atrial fibrillation, do you suggest to measure troponin to every patient, or do you suggest to measure it in some patients only? Thank you.
So it's a difficult question. It's a challenge. I think if a patient has atrial fibrillation and clear evidence of sustained ischemic symptoms in the context of a lower rate than you might anticipate to cause those symptoms, or in someone who's got clear regionality to the ischemia on the ECG, I think it's reasonable to look to see if there's evidence of myocardial infarction. I think measuring troponin concentrations in all patients with atrial fibrillation, you'll undoubtedly pick up some patients who perhaps have subclinical ischemia and they have a small elevation of cardiac troponin, and you might not be sure what to do with them. So my suggestion as a pragmatic level would be, if someone's got sustained ischemia at a low rate or very regional ischemia, then consider troponin.
Thank you very much, Andrew. Excellent talk, as always. So in my clinical experience as a cardiologist registrar, it's sometimes very frustrating because you have to see many patients in the emergency department which were diagnosed with type 2 myocardial infarction, although they do not have clear signs of ischemia. So I found it personally very, very difficult to detect objective ischemia. So what's your personal opinion? What should be the next step? Which patients should really get an echo, for example, to look for regional wall motion abnormalities? What's your opinion on that?
Thanks, Jasper. I think the ischemic criteria are very pragmatic, and I can see why they were attractive when the guideline was drawn up, because we understand ischemia, we have criteria for myocardial ischemia in our head, and we can see those patients. But actually, when you look at the totality of the evidence, comparing patients with type 2 myocardial infarction and those with acute myocardial injury without ischemia, the rates of future myocardial infarction, cardiovascular death, are higher in those who have acute myocardial ischemia. And that might be because at the moment we're ignoring those patients and we're not giving them the same level of investigation and treatment. So that's my hypothesis, and certainly going forward, one of the studies I'd like to do is looking at the role of ischemia in the diagnosis of type 2 MI and acute myocardial injury. Does it actually differentiate the presence of obstructive disease, late gadolinium enhancement, or indeed inducible ischemia, or perhaps could the classification be refined?
So thank you very much. It's a very complex, confusing area. So what we've been looking at is biomarker combination, but the theory is that if you develop supply-demand mismatch for whatever reason, that will occur over some time and you get wall stress, and then that wall stress will eventually result in injury or whatever you want to call it. So we've been looking at the NT-proBNP to troponin T ratio. Mm-hmm. And what it appears is the higher that ratio, the more likely is that it's supply-demand mismatch. And while it's not perfect, I think it's a sort of an interesting way to try to differentiate, because the mechanism is different. And the type 2s don't come in and say, 2 hours ago I got sudden onset, I didn't feel well, I got pneumonia. And so I think that maybe biomarker combinations and maybe you would like to look at that in your...
Certainly, it's an interesting area, and I think what you're describing is the correlation between whether someone has stress and has another insult leading to that stress, which can be associated with the type 2 MI. Mm-hmm. And one of the great things about demand MI is that we were funded to bank samples, so we're very interested in looking at these things in future.
Okay, well, if there are no more questions, then we'll move on to the next speaker. But Andrew, thank you very much for that excellent talk.